my name is Sasha Birge. I'm a physiotherapist and athletic trainer by background. Today's practical will focus on the utilization of objective measurement technology to enhance a criterion-based rehab program for lateral ankle sprains. In addition to being one of the most commonly sustained lower limb injuries, lateral ankle sprains are very often overlooked and underappreciated. This can lead to patients self-discharging when they feel pain-free, even if their full function has not been restored. This can be the case in both clinical practice and in the high-performance sporting landscape. This can increase the risk of patients going on to sustain subsequent sequelae such as chronic ankle instability. Recent literature has suggested the need for criterion-based rehabilitation for ankle sprains. Unlike ACL and hamstring injuries, where there have been clearly documented rehabilitation programs with criterion-based progressions for these two injuries, the same hasn't been developed for ankles. In this practical, we're going to highlight a few different objective measurement assessment techniques that can be used to help inform a criterion-based rehab progression following a lateral ankle sprain. So one of the common impairments that we find after a lateral ankle sprain is a patient's inability to invert. So a lateral ankle sprain is a result of a stretching of the lateral structures. And so when we go to assess an individual, we want to see their ability to reproduce that movement, if it's limited by pain, and to what degree they're able to perform that movement on the involved side compared to the uninvolved side. So one of the things that we'll do is we'll use an inclinometer to measure that. So I can easily take the device and just strap it onto the individual's foot, put them into a neutral position, and I'll get the test started, and what I'm looking for here is essentially how much the patient can invert. So what I'll do is I'll say, Sammy, what I want you to do is just turn your foot in as far as you can when you get to the end point and hold. Go for it. Go turn in. Good, and relax from there. I'll get the measure, and then we'll have them return just to the starting position. I'll often do 2 or 3 repetitions of these depending on how they're going. Normally they'll be limited by pain in the initial phases after the injury, but if they start to get more and more range of motion with each repetition, what I want to see is their true max value, and then I'll compare that to the other side. I might do the uninvolved side first, just so the patient is aware of what I'm going to be testing in this initial examination. So once we've assessed range of motion, we also want to assess strength, both of inversion and of eversion, not to look at just total strength, but rate of force development, and we want to look at the ratio of inversion to eversion. So using the same device, I'm going to place my patient's foot in neutral. I like to stabilize proximal to the lateral malleolus, and then apply the dynamo or the handheld dynamometer that you're using just to the inside of the foot. I'm going to tuck my elbow in to my hip. Now ideally I don't need to be on a swiveling chair because it might make me less stable, so I can stand in this position. I feel fairly comfortable, then I'm not going to move and get a good isometric measure. So I'm going to place the device in position, lock my hand in place so that I'm in a good blocking position. I'm going to say to my patient, what I want you to do is push into the device as hard and as fast as possible. So we're going to get a max strength measure, and we're going to get a good measure for rate of force development. So in this position, just right here, make sure I'm stable. And Sammy, when I say go, you push in as hard and as fast as you can, 3, 2, 1, go. Push, 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 and relax. Good. So depending on how the measure looks, I'm probably going to do 2 or 3 reps in total. If the patient continues to express more force each time, I'm going to continue to do reps because I want to see what their max force output value is. So then what I'll do is I'll move on and do the same thing in eversion. I'll just switch around for that test. Get myself into a good position. I'll probably switch my hands for this one as well. So similar setup. My hand is supporting just proximal to the lateral, medial malleolus in this case. I've got my elbow locked into place, ankle in a neutral position, and then from here, I'll have the same instructions. So Sammy, what I'm going to have you do is push in as hard and as fast as possible. 3, 2, 1, go. Push, 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 and relax. Good. And I'll get my measure for that. Same thing applies. I'll do 2 to 3 reps. If the patient continues to express more force, what I'm going to look for is as many reps as we need until they get a max output and then start to decline. So I'm getting a true understanding of what their max force is and rate of force development. I'll then go on and do the same thing on the other side. Again, typically looking at the involved side second, checking the uninvolved side first so the patient knows what it is that he or she is going to be doing. To restore strength and function to the lateral ankle musculature and dynamic stabilizers, we'll start with a progressive yielding isometric by abducting with the band around the midfoot. And then we'll progress to a through range movement with the band around the foot. Keeping the band around the forefoot and the resistance applied to the ankle roughly the same, we then progress to weight bearing with banded lateral steps. We then progress to a banded side plank march, which challenges the lateral ankle structures on both the stabilizing leg and the moving leg, as well as increasing the load on the proximal structures, especially at the hip. In a wide stance, we progress from a closed chain lateral squat, continuing to challenge the lateral musculature of the ankle, as more of a stabilizer in this case, to a lateral lunge, working on accepting load, stabilizing and producing concentric force, to a skater jump, progressing the same qualities required for the lateral lunge, just at a slightly higher amplitude. So one of the other things that's important to assess following a lateral ankle sprain, which we often see impaired following these injuries, is joint proprioception. Now we can use the same inclinometer device to measure joint position sense, both actively and passively. The way I would do that, put the ankle in position, I'll start my assessment, and I'm going to put the patient in a position passively. So I'm going to move them into a position I can see exactly how far they've gone. Good. That's in that position, perfect. I'm going to bring them back, and the patient's seen how far they've gone as well. Then what I'm going to do is say, Sammy, what I want you to do is close your eyes this time. Go ahead. I'll start the test. And then, Sammy, what I want you to do is bring your ankle into the same position I had, and then let me know when you feel like you're there. There? Perfect. Awesome. And then return to that position. So what I can do is objectively measure someone's joint position sense, both actively and passively. Passively in this case, by determining what measure they get when I put their foot into a certain position, and then I can see exactly how close they get to that position by determining what degree the ankle is in when I first set it versus when they replicate that. It's a really nice way of measuring joint proprioception actively, and we could do that with inversion, eversion, plantar flexion, and dorsiflexion using the same device. One of the common impairments that we may overlook in our assessment is a patient's ability to bear weight through that injured limb. Now, we'll often conduct an auto ankle rules assessment, whereby we determine if they can bear weight at the time of the injury and when they present at clinic. But one of the things we want to do is we actually want to quantify their ability to weight bear before we start to do things like lower limb assessments on the one side. So what we'll do is we'll use the force X and actually quantify the difference in load through both legs in stance to begin with. So if Sammy here has a left-sided ankle injury, what I'll do is I'll have her stand on the plates in what she considers to be a comfortable position. And I'll show her that the orange line indicates all the load or force or weight being put through the right leg, and the blue is left. And I can use this as a bit of a training or a feedback tool to help Sammy understand how much weight she's shifting. So Sammy, what I want you to do is comfortably just shift to the left side to what you'd consider like a 2 to 3 out of 10 pain. Go ahead and shift a little bit. Perfect, nice. Even you're able to do a little bit more on the left side. Excellent, come back. And this time do a little bit more. And so what we're doing is we're using the force trace to give us a little bit of augmented feedback so that Sammy can see how much weight she's putting through her injured side, but I can also get a good idea of how much load she's able to put through that leg. Because what I want to do is subsequently move on to some of my single limb assessments, but I don't want to just jump to a single limb assessment like a balance or a squat or even a hop test on one leg until I know and my patient is comfortable bearing full weight through that side. So ultimately what I want to be able to see, and she's saying, let's go as far as you can, try and get all your weight on that left side. I want to be able to see her accept just about full weight through that left side before I'm comfortable to go into some of my single limb assessments. So once we've established our patient's ability to weight bear on both legs, we'll then move to assessing things like single leg balance, both statically and dynamically. So there's plenty of literature to support that static and dynamic balance are impaired after a lateral ankle sprain. And what we want to do is quantify those impairments using a balance test where we track center of pressure using the force X. And what we're going to do is conduct a test on both sides, comparing the uninvolved with the involved side. And I'm just going to walk you through the cues here of how I would perform this. So, Sammy, what I want you to do in this first test, keep your right foot so that the midline of the foot or line going through the center of the foot is parallel to both edges of the plate. Keep the hands on the hips. We're going to balance for 10 seconds. So what I want you to do is shift your weight onto that side in this position, get nice and comfortable. And when you're still, I'm going to start the test. All right. So you're going to maintain a still position, trying to move as little as possible. So by definition, static balance is one's ability to maintain equilibrium over their base of support with as little movement as possible, essentially establishing a static environment for the body's position. Sammy, when you're ready, go ahead and shift into that position. Tell me when you're steady. Feel steady there? Good, you can go ahead and look straight ahead and I'm going to start the test. Perfect, hold nice and still. And what I'm seeing on the screen with that orange line being drawn is essentially the tracking of Sammy's center of pressure through the time that the test is being performed. Good, and go ahead and relax. And what we see with the data here is the center of pressure range, in other words, how much that center of pressure point moves medial-laterally, so side to side, and then anterior-posteriorly, front to back. And we're going to compare that to the left side, assuming the left side is injured in this case. So same thing here. Make that foot so that it's parallel to either edge of the plate. When you're ready, go ahead and shift onto that other side. Good. Let me know when you're in a comfortable position. Good to go? Perfect. And we'll start that test. So we're looking at the same thing here. And we're seeing a slightly larger amplitude of movement. So after the injury, you might see the patient a little bit less stable, exhibiting a larger center of pressure movement on that side. Go ahead and relax. And so what we get immediately is the measurements for center of pressure movement in both the anterior-posterior and medial-lateral directions. And we get a percentage difference between the involved and uninvolved sides for center of pressure trace in this static balance assessment. For static balance training, we use a single leg stance with the patient circulating a weight, or a kettlebell in this case, around their body, essentially changing their effective center of mass, requiring them to maintain stability and resist large amplitude sways. Like most balance exercises, we can progress this by modifying conditions such as having the patient stand on an unstable surface, or by having the patient perform the same task with his or her eyes closed. So once we've established the patient's ability to perform a static balance test, we'll then want to move on to dynamic balance. So unlike static balance, where we're looking for them to be perfectly still, dynamic balance is their ability to maintain equilibrium while moving their center of mass as much as possible relative to their base of support. So my cue to Sammy is going to be a bit different this time. I still want her foot parallel to the either edge of the plate. That way our data is going to be accurate, and we're going to know that medial lateral movement of her foot is picked up as medial lateral movement of the plate, and same thing for anterior posterior. So Sammy, go ahead and shift into that position where your right foot is straight in line with either edge of the plate. And then what we're going to do is we're going to have you shift onto that side, hands on the hips. And then from here, what I want you to do is you're going to move as far forward as you can, far back, and then side to side. Good. And just stand up nice and tall. I'll begin the test in 2 seconds. What we're going to do is give Sammy a little bit more time because it will take a little bit of time to get through those 4 positions. So you'll have 15 seconds. Ready? Good. And go for it. Nice. Shifting forward, then back. Good. And side to side. Perfect. Awesome, and that's your 15 seconds. Go ahead and relax. We're going to do the same thing on the other side. And we can see the data here. We'll discuss it when we compare it to the injured side. But what we're looking for, unlike the static balance, is maximal movement or maximal displacement of the center of pressure in all 4 directions. So when you're ready, go ahead and shift to that side. All good to go? Yeah. Perfect. And go for it. Feeling okay? Good. 3 more seconds. Excellent. So interestingly enough, we can see the data here. In the medial lateral direction, there is roughly the same amount of movement on both sides. But in the anterior posterior direction, there's over a 70% asymmetry. To target dynamic balance, we use external constraints, in this case kettlebells, to encourage the patient to reach outside his or her base of support, which requires her to increase the excursion of her center of mass. So another thing that's important to assess is calf strength. Now, after a lateral ankle sprain, there's good research showing that arthrogenic muscle inhibition can cause weakness in the calf. And what we want to do is use the protocol that was introduced by Lee et al. In 2023 to measure calf strength, specifically the soleus, looking at both overall strength or peak force and rate of force development. So in this position, I've essentially got Sammy at a 0 knee to wall. I use the foam roller to line it up so that the knee and the toe are at the same distance. And my cue here is for Sammy to essentially plantar flex or point the toe down as fast and as hard as possible. So we're getting good rate of force development and good peak force. What I want to do is just stabilize this so it doesn't move. And Sammy, when I say go, I want you to push as hard as you can, as fast as possible into a calf raise, all right? 3, 2, 1, go. Push, 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 and relax. Good. Excellent. We've got the rep there. Might do 2 or 3 reps on that side, and then we'll do the same thing in the other. For the purposes of this prac, we'll just do one side. To help restore force production of the plantar flexors, we begin by alternating yielding isometrics using a calf raise machine or some other variation. We then progress to using eccentrics with a 2 up, 1 down technique. And then finally, we load unilaterally through range. So one of the things that we'll assess after lateral ankle sprain is an ability to squat. We'll do it double leg, so double leg squat, and we'll do a single leg squat. But the ability to quantify a patient's force expression through the movements and the different phases of those movements will give us a better idea of whether they're capable of performing at a level that we want, and if we're confident to move them on to the next phase of rehab. First thing we're gonna look at is just a squat here. So I'm gonna instruct my patient, I'm gonna say, Sammy, look, I just want you to get in a position that's comfortable, a position you would typically squat in, comfortable with your feet, and then with your hands, you can put them out, put them wherever you like. So get a nice, stable position first, so when you're in a comfortable position, let me know. All good? And then when you're ready, just go down, perform one squat and back up. Good. Nice, and hold for a second. So what we're looking at here is the different metrics. We'll look at things like eccentric mean force asymmetry to see on average through that eccentric phase which leg is producing more force. We can look at squat depth as well by measuring displacement of the center of mass, and we can see how far down our patient squats. And I might look at concentric mean force asymmetry to see on average during that concentric phase as the patient comes back up, which leg is producing more force. When you're ready to get into position, let's just do one more if that's all right. Nice and comfy. Perfect. Good. I should be better there. So what I noticed is Sammy was moving a little bit before she did that squat. And one of the things that we want to make sure that our data is accurate is there's as little movement as possible. So you'll be able to see that on the force trace there. But Sammy moved around a little bit and then went right into the squat. What we always want to encourage our patient to do is get into a nice stable position so the force trace is solid, and then perform that movement. So Sammy, what I'll have you do is get into position and tell me when you're ready, and then I'll have you do the squat. All good?
Yep.
Nice and still. The trace is even. And go for it. Perfect. That looks much better. We begin to restore squat mechanics using a TRX or a suspension trainer. This can allow the patient to rely as much or as little as possible on their upper body, and they can also sit back more, achieving their squat depth with very little dorsiflexion required. We introduce a heel-elevated goblet squat, allowing the patient to work through their range of motion while limiting the dorsiflexion requirements. And lastly, we'll progress to a barbell back squat on a flat surface, increasing the overall load as well as the closed chain dorsiflexion requirements. Once we've determined that our patient can competently perform a double leg squat, meaning that their depth is adequate and their concentric and eccentric mean force asymmetries are less than 10%, meaning we've got a 90% limb symmetry index that they've achieved through both phases, we'll then move on to the single leg squat. And what we'll do, Sammy, when you're ready, go ahead and shift your weight onto your right side. Stay nice and steady. I want to make sure the trace is flat before she goes into her squat. Go ahead and do a squat when you're ready. Nice. Good, reps been picked up. Go to the other side. Hold steady for a sec. I don't care if it's a pistol squat or a skater squat, as long as the same technique is used on both sides. Trace is nice and stable. Sammy's on her left leg. When you're ready, go for it. Nice. And relax. And what we're looking at here is a few different metrics. We're going to look at the eccentric force and the concentric force, and we're also going to compare the depth on both sides. So once we've looked at the squat, the other thing we want to look at is eccentric force absorption capacity. Now, we can do this using a squat assessment, but I'll use the tag features in ForceDeck so that I can distinguish this from my normal squat pattern. What we're going to look at is what we would call a drop squat or a tall to short or a snap down. Everyone's got different terms for it. So what we'll do is we'll have our patient go into tall position, snap down, and then come back up. We can progress to a single leg variation, but for the purposes of this prac, we'll probably just show the double leg variation. To perform these reps, what I want Sammy to do is really slowly rise up with your hands and your toes and hold that position for a second. Good, hold, make sure the trace is steady, and snap down. Good, slowly come back up. And that'll pick up our squat assessment. This time, let's zoom in on the metrics. So what we're looking at are mostly eccentric metrics. So let's do the same thing again, Sammy. Really, really slow, come into that position, and hold, 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 and snap down. Good, really slow, come back up. Awesome. So what we're looking at here is our eccentric metrics. We look at eccentric peak force asymmetry. So during that eccentric phase, we've got our max forces on either side. We want to see which leg is putting more force in. We look at eccentric peak velocity as well, and then we look at the eccentric deceleration impulse. So essentially, when Sammy starts to slow that velocity down, how much force is applied during that phase from slowing down until hitting that bottom point, and we get that bottom point by measuring the maximum negative displacement. We would do the same thing in a unilateral variation, but just for the purposes of this prac, we may not do that now. To train eccentric absorption or deceleration, I like implementing a 2-to-1 tall to short or drop squat, going from a bilateral stable base to a one-legged squat hold. Another impairment that we look to assess after a lateral ankle sprain is landing technique or force absorption. How well can a patient land softly and achieve a point of stability? So we do that with the double limb land and hold task, and then we progress it to a single leg. So what I'm gonna have Sammy do here is stand nice and comfortable behind the plates, and you're just gonna jump forward and land on both plates. So what I want you to do, jump forward, land on the plates, land as soft as you can, stick the landing and hold that position. I'm gonna tell you hold until the rep is detected, all right? And when you're ready, go for it. Nice, hold, 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 keep holding, keep holding, keep holding, and relax back up. Awesome. We're looking for time to stabilization, so how long it takes from when Sammy arrives on the force plates to reaching a point of no movement or stability. And we also look at the peak drop landing force, so how much force does she land with both sides, and compare the two. After we've conducted a double leg land and hold task and we look at our patient's ability to absorb force on both limbs, then we move to the single leg variation. Often we just use the double leg as an intro for the patient so they know what it is we're gonna do, and it gives them a little bit of comfort when they transition to the single leg task. We'll often start on the uninvolved side. So Sammy, what I want you to do is stand behind the right force plate. Nice comfortable position. You're gonna hop forward, land on the plate, land as soft as you can, and stabilize as quick as possible. I'll have you hold that until the rep is detected, all right? When you're ready. Good, hold, 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 keep holding, keep holding, keep holding, keep holding, and relax. Good, hop on off, excellent. Let's go back. So just like the double limb test, we see peak drop landing force and time to stabilization, but then we'll get an asymmetry measure and compare it to the other side. All right, when you're ready on your left leg, good, go ahead and hop forward. Good, hold, 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 stable, 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 and relax. Perfect. So let's look at the results. Awesome, so we can see the comparison here between time to stabilization on both sides, as well as the peak drop landing force on both the left and the right limb. And what we can also do is progress both the double and single limb land and hold tasks by having the patient start the test from a different position. So we could have Sammy start from a box, jump off the box and do a land and hold. So what we're looking at is Sammy's ability to reduce force and attenuate those forces from a height. We could have her start further back, so we increase the distance. When we go to the single leg task, we could do the same thing, but we could also start from a different point. So I could have Sammy start behind the box and go forward. I could have her start to the side of the box, jump medially or laterally. And what we're doing there is looking for different impairments that we might expose through challenging her in those movements, and then use our intervention to target those respectively. After we've established that our client is able to attenuate forces in a landing task, then we can introduce a jump. And we'll do that first bilaterally and then progress to a unilateral variation. So we'll do this using the counter movement jump. So my cues to Sammy here are hands on the hips, and I want you to jump as high as you can, as fast as you can get there. So that's quick, down and up into the air, and land nice and soft. All right, ready to go? Go for it. Nice, good. And that'll give us all the metrics we're interested in. And what we're looking for here is a combination of different metrics during the eccentric phase, as well as the movement depth, the concentric phase, how high Sammy jumps, and some of the landing strategies, in addition to things like RSI modified, which tell us a little bit more about how efficient Sammy jumps. That's a metric of how high she jumps relative to the time it takes for the contraction. Let's do that one more time when you're ready. Good. Awesome. The first thing I look at is eccentric peak velocity, which tells me the maximal speed that the patient reaches during that downward phase. And this tells me a bit about the patient's intent to move or how quickly they're moving when they perform the movement. The second thing I look at is eccentric deceleration impulse. In other words, the amount of force that's applied through both legs from that point of eccentric peak velocity until counter movement depth, or the bottom of the movement. And that'll be the third thing I look at, is counter movement depth. In other words, how far down does the patient's center of mass move when they go to perform the counter movement? And then we look at the concentric phase. So I look at the concentric impulse and I compare the amount of force applied through both limbs. Then I look at jump height to see how far the patient moves vertically in the air during the flight phase. And lastly, I look at the RSI modified, which is a measure of efficiency, which is calculated by the overall jump height divided by the contraction time. Some people refer to this as the input relative to the output. So the amount of time that it takes from the initiation of movement till takeoff relative to how high the patient jumps during the flight phase. We use the TRX suspension trainer to help reintroduce jumping, as this provides confidence to the patient and allows them to progressively load more and more through their lower limb by relying less and less on their upper body for help. We then progress to assisted jumps, allowing the patient to achieve greater concentric velocity while still landing with less force than they typically would. And lastly, we progress to a resisted jump in order to put greater force production demands on the patient as he or she progresses through the later stages of their rehab. Once we're happy that our patient is competent to perform a double limb jump pattern using the counter movement jump, we'll then progress to the unilateral variation with a single leg jump. Awesome, Sammy. When you're ready, go ahead and shift onto the right side. Stay nice and steady first, and jump as high as you can, fast as you can get there. Good, awesome. Shift over to the left, same thing. As high as you can, as quick as you can get there. Go for it. Perfect, and relax. So once we've assessed jumps, we then move into pogos, and pogos are gonna isolate that calf-Achilles complex. When a patient does a jump, often they can just use their knees and their hips and not really expose the ankles to greater range of motion. But when we perform a pogo, we really put more demand on that tricep surae complex, and we're looking at stiffness, reactive strength, and contact time, seeing how much force the patient can produce on both sides. And then ultimately what we'll do is progress this to a unilateral variation, but for the purposes of this prac, we'll just look at a double leg. So my cue here for Sammy is hands in the hips. You're gonna perform one little jump, and then for each rebound, you're essentially gonna hop, bouncing off the plates as fast and as hard as possible, spending as little time on the ground and as much time in the air as possible. So I'll demo, it'll be just like this. I often provide a demo for something like this in case it's something that the patient isn't familiar with doing, all right? When you're ready, you start going and I'll count it down, and go for it. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, perfect. And we've got our rep. So we will look at a few different things in this test protocol. We'll look at things like active stiffness. That essentially refers to the vertical translation of the center of mass over the relative force for each rep. We've got the RSI, which is the efficiency, in other words, how much time Sammy spends in the air or jump height relative to the time that she spends in contact with the plates. We look at that contact time, and we look at the jump height as well in isolation, so we can compare them to future tests. To help restore reactive strength in the lower limb, we start with an assisted pogo. We then progress to a resisted pogo to increase overall demands on the movement. So once we've assessed our patient's ability to perform a double leg pogo and a single leg pogo, then we want to challenge her in the frontal plane doing what's called a hop and return. So it's like a single leg pogo, but moving laterally side to side. So starting on one limb, other plate, and then back. So what we're doing here is challenging the medial and lateral structures of the ankle respectively with this jump. So Sammy, what I'll have you do, shift your weight onto your right leg first, hands on your hips, and you're gonna basically hop to that plate and back, spending as little time on that plate as you can. Good, and relax. Perfect. Now same thing on the other side. Go ahead and stand on that left one, make sure the chase is nice and steady, 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 and when you're ready, go for it. Good. Perfect, and relax. That's great. So what we can do is we can compare the contact time on both sides as well as the time to stabilization after that jump. We use a band-assisted variation of the hop and return to restore lateral hop function. So once we've tested pogos, both bilaterally and unilaterally, we then progress to a drop jump and a single leg drop jump respectively to add a little bit more amplitude to the stretch shortening cycle and challenge reactive strength a little bit more. So Sammy, for this one, what we're gonna do, hands on the hips, you're basically gonna hop off, perform a pogo, jumping off as quick and as hard as you can from the plates, as little time on the plates as possible, and then landing. When you're ready, go for it. Perfect. So we might do 2 or 3 of those, just like some of the other tests that we've done. And for the purposes of this prac, we're not gonna progress to the single leg version, but typically what we would do is after we're happy with this, progress onto the unilateral or single leg drop jump. Thank you for watching this webinar today. For more information, please feel free to contact me using the details provided here. And please stay tuned for future webinars.